So the coffee and brownie break is over, and we're going to kick off again. Our continuing talks about themes of innovative ways to help with care is going to continue, and our next speaker is Dr. Joshua Grill. Josh is an assistant professor in the Department of Neurology at UCLA, and he's the director of the Catherine and Benjamin Kagan Alzheimer's Disease Treatment Development Program and director of the UCLA ADRC Recruitment and Education Core. And Josh is going to tell us about some very interesting aspects of the neuroscience that helps to bridge music and dementia.
Good afternoon. So let me begin by saying thank you to Dr. Glasgow and the other organizers for the invitation to come talk to you today about a program that we've been doing. My disclosures are here for your enjoyment. A more important disclosure, I think, is to acknowledge Dan Cohen, the originator of a nonprofit organization called Music and Memory based out of New York. Dan is a geriatric social worker who was actually featured, I think, just in the last week or two on ABC News as an American hero or the strength of America, something along those lines. Dan has really spearheaded this idea of trying to bring individualized music interventions to patients with dementia nation and worldwide. He's also part of a new movie that was just given an award at the Sundance Film Festival. And to get us going, I'm going to play you just a brief clip from that movie. You'll hear Oliver Sacks's voice.
Unresponsive and almost unalive.
Henry.
Yeah?
Henry.
Yes, sir.
I found your music. You want your music now?
What do you want me?
Let's try your music, okay? And then you tell me if it's too loud or not.
Then he is given an iPod containing, we know, his favorite music. And immediately he lights up. His face assumes expression, his eyes open wide. He starts to sing and to rock and to move his arms, and he's being animated by the music.
And he used to always sit on the unit with his head like this. He didn't really talk to much people. And then when I introduced the music to him, this is his reaction ever since.
So I like to let it run to just that point for a few reasons. The film is actually called Alive Inside. I admit to not having seen it because, unfortunately, my academic career prevents me from attending Sundance Film Festival. But I aim to see it as soon as possible. I like to let the movie run that long because I think it's a nice demonstration of the impact that music intervention has on that one individual, but also on his caregiver. She clearly connects with the individual she's providing care much more after this opportunity to awaken something inside of this gentleman's mind through music intervention. The Music and Memory program that Dan Cohen started has had numerous successes, and it's being embraced by, indeed, departments of public health in various states and countries. And this is outlined here, and I would refer people to their website. The reason I'm here is that when I heard about Music and Memory, I was, as you might be right now, quite taken with the idea. And as you heard earlier today, our field has really moved more and more toward prevention, earlier and earlier in this disease. And at our research center at UCLA, I've embraced that. In fact, much of my independent research is about how we do prevention clinical trials. But I didn't want us as a group to walk away from the millions of people who have dementia and the hundreds of thousands of people with severe dementia in Los Angeles County and greater Los Angeles area. So we began a program in partnership with Dan and Music and Memory to collect charitable donations of iPods, MP3 players, and iTunes gift cards that we then in turn donate to different organizations, assisted living and nursing homes in the greater Los Angeles area for use in this manner. Since beginning that program, I'll say the response has been quite amazing. We've been fortunate to have quite a bit of media in the local news and radio, stories about our program, and especially since the production of a UCLA-based newsletter called Vital Signs, I've been receiving incredible emails and videos and other anecdotes from people, frankly, worldwide, some of which I'll talk about in my talk today. So this is meant to serve as a backdrop for my talk, in which I'll try to do these things. I will try to convince you that music is a ubiquitous and powerful entity. I'll spend a little bit of time talking about the neuroscience of music, specifically what music does to our brains, and I will try to link these things together in talking about music and dementia. So I'll say that I have taken much of what I've learned about the neuroscience of music from one specific laboratory, the laboratory of Robert Zatorri at the Montreal Neurologic Institute and McGill University in Montreal. This image comes from a review paper by Dr. Zatorri and one of his previous students, Valerie Salimpour, in PNAS. This is a bone flute made from the femur of a vulture. It is not unique. Many of these instruments have been identified. Radiocarbon dating puts this back into Paleolithic times, more than 30,000 years ago. It's clearly not a first-generation instrument. If you had the opportunity to inspect it closely, you would see that where the holes are placed in this flute, there are lines showing that the individual who created it had measured exactly where the holes needed to be. I include this just because it is meant to say that for as long as we're aware, humans have had music as part of their society. Music is ubiquitous to cultures and ethnicities and races. It is conserved. Why? Why has music existed this long, and why does it consist? Why does it persist? It's useful. It helps armies march and athletes train. And it is powerful. And this power can be evidenced in a mother singing to her infant, and it can be evidenced in health. There are a number of examples in the literature of the impact on health of music. Many of these, most of these, are neurologic. This is from Oliver Sacks's paper in Brain, where he describes the composer Lucas Foss, who had become extremely debilitated in his Parkinsonism, yet once he sat at the piano, was graceful, elegant, gliding in performing music. And as soon as he stopped, his tremor and bradykinesia was back. Another paper dating back even further by James McCarthy in Annals of Neurology in 1979 describes the case of a Parkinsonian patient who, while at home alone, experienced an inability to move, a feeling of his feet being glued to the floor, until a Sousa march came on the radio and he was propelled back into motion, leading him to consider carrying around some sort of personal music-playing device so that if this ever happened again, he could use music to get him moving. If only such devices existed, right? So I have to say, I have used my ARS questions quite differently than what has happened so far today. So the first one is already here. So if you'll use your device and tell me, have you ever experienced chills or chills down the spine in response to music? Okay. Do we have our answers? All right. Me Too. One study suggested that the opioid antagonist naloxone can prevent music from causing those chills. I'm going to come back to those chills. But other studies have been found to emphasize music's opioid or opioid-like activities and capabilities. This is just a few bullets of summary from a Cochrane review looking at music as an analgesic, music as an ability to reduce pain intensity, music as an ability to reduce pain post-surgically, and even music as an intervention to reduce the dose necessary of analgesics after painful surgical procedures. And you can see the summary at the bottom here. Not a huge effect, but a real one. Music's ability to actually reduce pain. It's not all good news when it comes to music, however. Sachs and others have written about musicophilia. Sachs, in his book by the same title, describes a New York surgeon who was struck by lightning. The account is really incredible. The man has a near-death experience. He's resuscitated by a nurse who happened to be vacationing at the same lake. He awakes from his state to say, "It's okay, I'm a doctor," and she responds, "For a minute there you weren't." He has a battery of tests performed. His EKG is normal, his MRI is normal. But a few weeks later, he does have some memory impairment, and a few weeks later, he develops an insatiable appetite for classical piano. First, he needs to hear it. Then he needs to play it. He has to buy a piano. Then he needs to compose it. He awakes with these beautiful pieces in his mind, and he has to actually learn how to write music so that he can compose piano. Obviously, this is a unique case, struck by lightning. There's another case in the literature, and I learned about it from a review by McGuire, of lamotrigine-induced musicophilia. A patient who was indifferent toward music, who after beginning lamotrigine for her epilepsy, suddenly wants to spend at least a few to several hours per day listening to classical music on the radio, and then begins dragging her family to every concert she can. So my next ARS, I'm going to try to turn the volume down a little bit here. See how this goes. Is what do these two songs have in common? And your choices are, they are by the same artist 3 decades apart. You'll get that in a moment. They were both performed on last year's finale of American Idol. Or they are both documented stimuli, causing musicogenic epilepsy. I think I had already given away the answer anyway. Let's see.
The girl them skill tip. Some give it to, some give it to, some give it to our girls. 5 million and 40 naughty shorty. Baby girl, all my girls, all my girls. Thunderball say, well.
Here's the other one. All right. So of course, were we going to do the answer? Yeah, let's do we'll skip the ARS part for this one. The answer is C. These are both documented stimuli, and you got it right. Congratulations. The first, by the way, was giving credit where credit was due, was Sean Paul. It's a song called Temperature. The second was a song by the Dooleys from the mid-1970s. And they are, of course, both documented cases in the literature of having caused musicogenic epilepsy, clearly in 2 different individuals. The song Temperature by Sean Paul was very popular one summer when this woman, Stacy Gale, noticed that it was directly related to her seizures. Her musicogenic epilepsy actually expanded to include other pop, urban contemporary artists like Rihanna. Her epilepsy got so bad that she had to drop out of school. because when students' ringtones had songs associated with them, they could put her into seizure. She was put into an observational epilepsy unit to try to determine the cause of her seizures. Her doctors did not believe her that music was doing it. They took her off her meds. They sleep deprived her. She was really fed up with the process after 4 days and said, "Give me my iPod." She fell asleep listening to that song by Sean Paul and had 3 seizures overnight. She actually dropped out of school, moved from New York back to her birthplace in Canada because music was so prevalent in her culture that she couldn't survive. And this quote from an article in Scientific American, I think, is really amazing. She says that, life without music is just something no one should have to go through. She actually had surgery to correct her epilepsy, neurosurgery, and that's her neurosurgeon next to her there. This is an exceedingly rare phenomenon. There are about 150 cases in the literature. It's 1 in 10 million people who experience this. It is by and large, temporal lobe epilepsy. It is often stereotyped for the type of music, a particular instrument, or even a particular artist. Most scholars on this topic conclude that it is not the music per se that causes the seizures, but the emotional context of the songs that elicit the response. And I think that's pertinent to the remainder of my topic. So now I'm going to talk a little bit about the neuroscience of music. I took this image from the textbook by Kendall, Schwartz, and Jessel that I hope is still in vogue. It was in vogue when I was a graduate student, learning the ascending sensory pathways. Of course, for sound, this begins in the inner ear and the cochlea, ascends through the auditory nerve, stopping in the brainstem where sound localization occurs. It goes into the inferior colliculus, up through the medial geniculate nucleus of the thalamus, and then to the primary auditory cortex, Heschel's gyrus. This is Brodmann's area 41 and 42. Zatori has hypothesized that much like visual information, we have both a dorsal and a ventral stream for the passage of sound information and especially music information. The dorsal stream includes going to motor cortices. How many of you tap your feet when you hear a good song? And the ventral stream includes prefrontal cortices and limbic areas that I'm going to talk a lot more about. This is a summary from Stewart, who tried to categorize the neuroanatomy of music, sensory appreciation of music. Heschel's gyrus is important to certainly tone and pitch, as are the secondary auditory association cortices. Rhythm and time are more involved, they involve motor cortex, cerebellum, and brainstem. In fact, some neurons in the brainstem have been found to mirror the beat of music. The recognition of music, its familiarity and its semantic knowledge, involves more temporal lobe structures, and I'm going to spend a lot of time talking about the emotional valence of music, which involves temporal lobe and mesolimbic structures. So I'm going to play a bit of music for you again. So this is what would be termed consonant piano music. It is in tone. It sounds normal to you, perhaps even pleasant. This is the same piece of music, dissonant. It's out of tune, it's out of tone. Probably should have done some ARS questions about this. So you can hear the difference between those two pieces of music. Zatori and his colleagues have undertaken a remarkable series of studies that I'm going to tell you about now. The first of which was to play one piece of music progressively altered to take it out of consonance and into dissonance at varying degrees, 5 different degrees of dissonance. So there are 6 pieces of the same overall piece of music, and then to image people while they listen to them. Can you see this? Okay, so here you see how participants in this study rated each of those 6 pieces of music And you see it's a largely linear relationship between the pleasure they derived and the consonance of that piece of music. The more dissonant, the less pleasurable. In contrast, they did not view any of these pieces of music as particularly happy or sad. It's about how pleasurable it is to hear the music. And specific brain regions and the activity, the blood flow of those brain regions was directly correlated with the consonance of the music. So the more dissonant the music was, there was parahippocampal gyrus blood flow increase, whereas for the more consonant music, that is the music more pleasurable, there was a great deal of orbitofrontal increases in blood flow, a little bit of cingulate cortex, and more frontal areas. They followed this up with, going back to our ARS question, putting people in a scanner who could reliably predict pieces of music that would cause them to get the chills. And they wanted to see what happened to the brain when an individual heard music that caused the chills. I think one of the ingenious things about this study is that the control is the other people in the study listening to the other people's music that doesn't cause the chills in them. So tone, pitch, timbre, all are completely controlled for. The only variable of interest is whether or not someone gets the chills from a particular piece of music. This was, again, an FDG PET study. Unfortunately, the resolution offered by FDG PET is not as great as what we can provide now. But they showed a few things. One, they had already done the psychometrics of this to show that they could physiologically characterize when a person gets the chills based on heart rate, body temperature, and galvanic skin response. So they could control what was happening and document that an individual was indeed having the chills when they reported having the chills. And they showed that particular brain regions, again, a little bit of orbitofrontal, but especially the ventral striatum, were activated when people got the chills from music. And in line with what we saw in the previous study, they showed a deactivation, or an activation associated with not having the chills, in the amygdala and the hippocampus. But I'm going to focus on this ventral striatum. Ventral striatum, of course, is part of the circuitry in the brain incredibly important to reward. This is the part of the brain that lights up when we have sex. It's the part of the brain that lights up when we eat chocolate. It's the part of my wife's brain that lights up when she goes shopping. It is evolutionarily conserved to make us feed. It's our evolutionary reward system. Zatori and his colleagues went on to do a PET study with, instead of FDG, C11 raclopride, which is a D2 dopamine receptor antagonist, and confirmed that, in fact, in the ventral striatum, and this study was overlaid with fMRI so that the sensitivity of being able to talk about specific brain regions was increased. And they showed that this was a direct correlation between getting the chills and experiencing pleasurable music and displacing C11 raclopride. That is, endogenous opioid was increasing in levels and knocking out this tracer in the PET scan. So a fairly clear demonstration, one that I certainly believe, of a reward signal, a neurochemical response to pleasurable music. And again, as a reminder, the control in these studies is listening to music that gives other people chills but doesn't give you chills. And I think ingeniously the most recent study that I'll tell you about from this group played more than 60 pieces of music to McGill, Montreal-dwelling college kids who had no musical training. All of the music was novel. They had never heard any of it. I consider myself quite cool after reading this paper and saying I knew 10 or 9 of these bands that all the Montreal kids knew. And they put them in an fMRI scanner, and they asked them to listen to these pieces of music and report how much they would be willing to pay on a music sharing website for each piece of music that they had never heard before. They were given 4 choices: nothing, 99 cents, $1.29, or $2. And they showed that there was a remarkable linear correlation between activation in the striatum, specifically the nucleus accumbens, and the caudate, and an individual's willingness to purchase these songs. Now, they didn't get the chills from these pieces of music. We're talking about, potentially not a huge response in the brain region, but a very clear relationship between pleasure and music activating particular brain structures that are evolutionarily conserved to cause us to experience reward. So in summary, I hope that with this portion of the talk I've convinced you that music activates the brain differently than does sound, spoken word, and that there's a perception network as well as an emotional and reward response network that music can activate. And now I'll talk a little bit about what I think this all can mean in dementia. So it's well described that music, the ability to enjoy, the ability to perform music, can be preserved until very late in dementia. This is from a paper of a single case study who would later be confirmed to have pathological criteria for Alzheimer's disease, of an individual who could no longer tie a necktie, but could still play trombone in a Dixieland band. One study actually taught residents in a facility a new song, a simple 10-line song over the course of 8 weeks. The participants, who were fairly severely demented, could not describe the sessions in which they were taught the song, but for months after would sometimes spontaneously break out into the song. This is a video that was sent to me by someone who read the article in UCLA's Vital Signs.
My dad has Alzheimer's disease. He's 79 years old. It's been about 20 years since he last played the drums, but I still wanted to give it a try. 10 minutes after making this video, he had no memory of our performance together. But yet, he can still make music like this. I wonder why.
Bad, right? That was them performing a concert at the assisted living where he resides. So clearly, music is preserved. This could be a motor phenomenon, it could be a memory phenomenon, it could be both. Can this be made into a therapy? This is a well-published phenomenon, music as an intervention or treatment for dementia. But it is a muddy literature at best. It's very difficult to assess this literature overall. Here I outline a few reasons why it's challenging to interpret this literature overall. The samples included in studies are quite diverse, including all-cause dementia versus Alzheimer's disease specifically. I should start by saying many of the papers are simple anecdotes or case studies, not rigorous controlled studies. One meta-analysis examined more than 800 papers, only to find 20 with adequate controls. Even among the studies with adequate controls, those controls vary. I read a paper recently looking at music versus having horticulture text read to a patient. I'm not sure why they chose horticulture, but you can get the point that there are a variety of different control groups used in these studies, things like cooking classes, usual care, typical activities for a particular nursing home. And perhaps most importantly, the interventions vary substantially from study to study. At many of the facilities that I've visited or given talks at, they often have music classes or music therapy. Music therapy has a very specific definition, and it involves a trained professional who is a music therapist. It involves an interaction between that individual and the patients who are undergoing therapy, and it involves the use of music. That's distinct from a musical intervention which is what we've been trying to help provide for severely demented patients in Los Angeles through iPods and personalized music playlists. So this makes it very challenging to assess this literature. And the literature talks about a variety of different types of outcomes, including both cognition and behavior. So you may have heard of the Mozart effect. I saw some of my colleagues from UC Irvine here. This was published from a group at UC Irvine in 1993, suggesting that 10 minutes of Mozart's sonata for two pianos improved the Stanford Binet standardized spatial reasoning task in college students. And this is a literature unto itself, that listening to Mozart can improve your IQ, improve your cognitive abilities. There were a number of studies that failed to replicate this, and indeed a bit of a literature-based argument between individuals in nature, of all places. I should be so lucky. And a really interesting idea, an interesting phenomenon. I admit to playing some classical music and pumping it into my pregnant wife's belly these days, just in case. In Alzheimer's disease, for whatever reason, most of the studies I've encountered trying to replicate this phenomenon have not used Mozart. They have used Vivaldi's Four Seasons. This is the spring movement, if I remember correctly. But again, looking at these studies, I find most of them are less than adequately controlled. A few of them have demonstrated significant effects, but only a handful of significant effects with a large battery of cognitive tests being thrown at patients, making it difficult for me to conclude that there is adequate data to suggest that music, individualized or otherwise, can improve cognition in Alzheimer's disease patients. In contrast to this, I find the literature looking at music as an intervention for behavioral symptoms to be much more compelling. As a reminder, behavioral symptoms are extremely common. They are more difficult for caregivers and families than our cognitive symptoms, and we have no FDA-approved treatments for these symptoms. As you heard in the last talk, it's critical that we try non-pharmacologic interventions, and many of them can be quite effective. These include trying to find mechanisms to avoid stimuli that elicit these behavioral symptoms, using reassurance and redirection, and trying to find other ways to distract patients away from whatever is causing or whatever is happening as it pertains to their behavioral symptoms. This is from an email I received in response to the Vital Signs article from an individual who unfortunately lost both a parent and a parent-in-law to Alzheimer's disease, but for both of them found music to be a helpful mechanism to both improve her interaction with that parent and to reduce the behavioral symptoms in them. For her dad, it was headphones with the Beatles, which she said made him calm and suddenly more responsive to her. And for her mother-in-law, and this is the one I really like, she would go visit the mother-in-law in the nursing home and bring a personalized music device. And it would always cause the staff at the nursing home to be grateful to her because it made the mother-in-law so much easier to handle. And she wondered to herself, how do these people not know this? There are a handful of studies that I'll tell you about that I think are worth discussing. They vary in their rigor, that used individualized music intervention, not music therapy, but music intervention, as treatment for behavioral symptoms in demented patients. The first is an extremely well thought out study by Linda Gerdner. It's a little dated now, it's from 2000. She categorized in a series of nursing home residents who were quite impaired. About half of them were non-ambulatory, half of them were dependent on others for toileting. The top line in this figure is the first 2 weeks of being in the study, characterizing a baseline level for verbal agitation. She then performed a crossover within subjects' design, randomizing half to classical music and randomizing half to preferred music, developed through what's called the Hardstock preference, music preference inventory, I think. She combined these then into one data set comparing classical music as an intervention to personalized music. And the other thing she did was she used the Cohen-Mansfield subscale to assess the peak period of agitation in these patients, and then applied the intervention 30 minutes prior to the daily peak. She showed that classical music was actually effective. It didn't become significant until about 20 or 30 minutes into the intervention, but it did persist after stopping the 30 minutes of music intervention. But personalized music, individualized music, was significantly superior to classical music in reducing agitation. This is a short time window, though. Another study by a group in Taiwan actually randomized 2 different facilities to individualized music treatment. Again, focusing on agitation as a primary outcome using the Cohen-Mansfield Agitation Index. They had skilled nursing facility nurses work with families and patients to determine patients' individual preferred music, and then implemented that again in a randomized setting. One care facility was randomized to placebo or normal control with no music. The other was randomized to receiving individualized music therapy, music intervention, for 30 minutes twice a week. And they showed that the Cohen-Mansfield actually was reduced, the overall Cohen-Mansfield was reduced by 9 points in the experimental group, not at all in the control group, and this was a statistically significant difference. Lastly, in much milder patients, a group from Scandinavia uses what they call an inverted U individualized music treatment, bringing the patient to choose the type of music that they want to listen to on that particular day, and the types are showed up on the left. And then they start with a rhythm that is somewhat faster, and then they slow the rhythm down, trying to calm the patient before bringing it back up at the end of the intervention to try to increase their mood. The primary outcome for this randomized trial, which was done in parallel, was the Hamilton Anxiety Scale, and that's the graph on the left. And you can see that the group that received music had a significant decline in their Hamilton Anxiety Scale ratings relative to the control. A few other important things about this. This was a once-a-week intervention for 16 weeks. And the last measurement was at 24 weeks, and the difference remains statistically significant. So it suggests not only a during intervention effect of using music as a treatment, but that this may persist for weeks after using music as an intervention. They looked at the GDS, the Geriatric Depression Scale, as well. It was a little bit challenging to interpret because the groups happened to be different at baseline, but the group randomized to music had a greater decrease in depression scores than did that in the controls. So these are just a handful of studies suggesting that individualized music could help people. How might this happen? There are a lot of different potential hypotheses. In the setting of group music treatments, there's the potential for increased social skills and camaraderie, and that this could improve mood. Certainly people like to talk about the link between music and memory, that the music may be associated with fond autobiographical memories. People have tried to do that to some extent. I haven't read a lot of papers that I felt were extremely rigorous in that regard. Could music, and especially music classes that involve playing instruments and singing, could it be a form of exercise for patients who don't get a lot of exercise otherwise? And could that have neurophysiological impact? Or, lastly, and what I will propose as a potential hypothesis, could music activate reward circuitry in the brain of someone with Alzheimer's disease, and could that have a positive effect on behavioral symptoms? So again, these symptoms are extremely common, and we don't have great understanding of exactly what structural and connectivity circuitry underlies who has behavioral symptoms and who does not. This is from a recent paper by a work group sponsored by the Alzheimer's Association that outlined 3 sort of general neurobiological hypotheses for why these symptoms occur in people with dementia. The potential for disconnection of frontal subcortical circuitries, the potential of disruption of corticocortical circuitries, including the limbic structures like the hippocampus and the amygdala, and malfunction of monoaminergic system, including norepinephrine, serotonin, and our friend dopamine. So what I think is interesting about these 3 potential neurobiological substrates for behavioral symptoms is that 2 out of 3, and according to Meatloaf, 2 out of 3 ain't bad, 2 out of 3 we've already talked about in relation to music. A recent paper by Bill Seeley and his colleagues at UCSF sort of lends, I think, some credence to this idea. This is examining volumetric losses in these striatal substructures in healthy controls, Alzheimer's disease, and behavioral variant frontotemporal dementia patients. And they find that, especially the nucleus accumbens, the atrophy associated with disease is greater in behavioral variant frontotemporal dementia than either of the other 2 conditions. In fact, Alzheimer's disease atrophy did not reach statistical significance relative to healthy controls. There was atrophy present, however, but it was certainly not to the extent that was seen in behavioral variant frontotemporal dementia. Moreover, they found a correlation between atrophy in these striatal structures and the presence of behavioral symptoms as measured by the neuropsychiatric inventory, a scale measured by one of my mentors, invented by one of my mentors, Jeff Cummings, that looks at 10 behavioral symptoms. And finally, a recent paper suggests that in behavioral frontotemporal lobar degenerations, or FTD, atrophy of these structures is associated with an inability to recognize the emotional valence of music, such that these patients can't tell you if a song is happy or sad if these brain structures are atrophied sufficiently. So this leads me to propose a potentially testable hypothesis that the mesolimbic anatomy and connectivity is maintained even until late in Alzheimer's disease, and that individualized music, that is, music that causes a particular patient pleasure, might activate these networks, and that activation of these networks could be used to reduce behavioral symptoms. Whether I'm right or wrong, music may help treat these very difficult symptoms that most Alzheimer's patients and their families encounter. It may have other potential roles. We are a research center, and it's very difficult to do a lot of these studies, especially in later stage Alzheimer's disease. Perhaps music can be used to calm patients when they need an MRI, when we want to do blood draws, or we want to do a lumbar puncture. And lastly, I think, I go back to the woman in the first video laughing, and also to the reports, the anecdotes from the patients and the caregivers who've emailed me, that I think the use of music in especially informal care settings could really have an impact on the perceived relationship with these severely demented patients on the part of caregivers. And even if that's the only thing that comes from this, would that not be worth doing? Because we're talking about something that's extremely cheap, it's low risk, and it has a lot of potential ways by which it could provide help, even if it's limited to quality of life as opposed to actual symptomatic improvement. So with that, I will summarize and conclude that I believe music uniquely activates the brain in a way that spoken word and tones cannot. I believe that music as an intervention could facilitate reducing behavioral symptoms and improving quality of life for patients and caregivers with Alzheimer's disease and other dementias. And that this yields itself to future studies that we may or may not undertake at UCLA to try to better understand the efficacy of these things, the ideal mechanisms by which they can be used, and the underlying neurophysiology. I need to acknowledge Dan Cohen from Music and Memory, who really sparked me to do this at all. I'm acknowledging here in the photograph the lead singer of the band that causes chills in me the most, who my wife got to meet, and I was at an Alzheimer's conference in Philadelphia. And I would refer anyone interested in this, and I apologize, I don't think my slides were made available, and I'm happy to provide them to anyone who wants them. I would refer the audience to some really excellent books and review articles that exist on this topic specifically, either the neuroscience of music or specifically in dementia, because there's a real wealth of scientific literature on this topic, and it is all quite fascinating. So thank you very much for your attention.